us today. This meeting is being recorded. It is my pleasure to introduce Dr. Bob Dickson for us today. Just a few things about Bob before he gets started. Bob got his medical degree from Duke University School of Medicine and then did a residency at the University of Washington in internal medicine. And then he came here as a fellow in internal medicine and pulmonary and critical care. Since he's been here at the university, he's won a number of awards, and I'll just name a few: an Early Career Investigator Award and a Science and Innovation Center Rising Star Award, both of those from the American Thoracic Society, and a Department of Internal Medicine Early Career Endowment Award. He is currently an Associate Professor of Microbiology and Immunology and a trainer in our program. He's the Associate Director for the Michigan Center for Integrative Research in Clinical Care, and also the Medical Director for the Washtenaw County Tuberculosis Clinic. So my dog's getting excited about all these awards. So Bob is an expert in all things airways, and his lab studies how the lung microbiome contributes to different patient outcomes with acute and chronic lung diseases. And we asked him to speak to all of you today. He's been a frontline provider during the COVID crisis in the University of Michigan hospital system. And we asked for him to provide his perspective about the disease and patient care. So thank you, Bob, so much for being here with us, and take it away.
Great, thank you, Nicole. Let's see. Are you seeing my slides?
Yes.
I see a thumbs up, and you are. Looks like it's full screen. Great. All right, I will proceed. So, hi everybody. Thank you, Nicole, for that very generous introduction. I, like many people, have not yet figured out how to give a good Zoom talk. So I am the kind of guy who typically paces around the room and tries to be animated and engaging. And if I see that you're zoning out, I come stand by you and I watch your face to make sure that I'm making sense and you're not scrunching up your forehead and confused. I obviously can't do that on Zoom. And I think people are wary of interrupting on Zoom because it kind of feels intrusive and rude. Please interrupt me. I don't want to monologue for an hour. I'd love to just chat with you and hear what kinds of questions you have. So by all means, interject. I know there's a hand raising thing, but I'm not sure I follow it. So just please just chime in and ask questions along the way. So I will, I have a bit of an agenda, but they're really just talking points to share the Michigan experience and specifically my perspective on the Michigan experience with COVID-19 so far, because it's by no means over. Nicole already told you who I am. Let's see if I can advance, but
my thing yet not.
I hear someone talking about, okay. Oh, I guess by ritual, I should say, please mute your mics unless you are interrupting me, which is what I'm asking for. So yeah, like Nicole said, I'm a physician scientist. So I am a faculty member with 2 appointments: pulmonary and critical care, which is my clinical home, and then microbiology and immunology. I'm 80-20, I spend 80% of my time doing research. I mentor a grad student from PIBS. I study bacterial communities in the respiratory tract and how they contribute to lung injury and critical illness. And that's what I do with most of my time, but I'm still a clinician. And like Nicole mentioned, I do critical care. So for instance, now I'm on service. I care for patients in the ICU, in our medical ICU, and our county TB clinic. So I am, like Nicole said, obsessed with all things related to microbes in the respiratory tract. And I live in Southeast Michigan, and we had one of the worst surges of COVID in the country up there. It wasn't quite as bad as New York City had, but it was pretty bad. So I think that's the motivation for having me talk to you and kind of share my perspective as someone who straddles the clinical side of our medical school's mission and the research side of what we all are engaged in. So what was the Michigan surge? So to put this all in sort of temporal perspective, yeah, there we are. You all remember that we first started hearing about this horrible virus and respiratory disease back in January. There were cases in Wuhan detected in late December, but they put a name to it, started tracking it and reporting it in January. And the real surge in cases came late January for them, and the deaths started surging in February. And one convenient thing for us is we have close collaborators. I'm on a grant with colleagues, friends from Beijing, and something the Chinese government can do that we cannot do in the US is mandate that physicians move from one part of the country to another. So Ning, my collaborator, was in Wuhan caring for patients there. And I had what I thought was a sort of privileged perspective of being able to ask her input on what this thing looked like up close, how they were treating it, what their immediate early clinical impressions were. But so February is when things were getting really scary. You all remember that Italy got it really bad. So the cases in Italy surged early March, the deaths really peaked towards the end of March and April. And we were about 2 weeks behind. And you can see on the right side of the screen, New York City on the top, and then Michigan on the bottom. And those cases in Michigan were clustered in Southeast Michigan, and really they were clustered in Detroit. And one thing we've seen is that it is hard to socially distance in an urban environment. And that's been a pattern across the world, and certainly in the US. But we got it pretty bad. And at its peak, there were in the state of Michigan about 150 patients dying a day of this. That translated into what we saw at Michigan. So we did have a fair number of cases that came in off the street, brought in by ambulances or walked in, but the majority of our severe COVID cases were actually transferred from outside hospitals, many in Detroit or around Detroit. So how did we prepare for it, and how did that preparation go? There was this sort of string of about 2 to 3 weeks where we knew it was happening, we knew it was coming. There was actually a case in Seattle in late January. We're kind of scrambling to get ready for it. And I think all in all, the university, the hospital, the county and state did a pretty good job of anticipating and doing what they could with the available resources and the time they had. The big thing we did, and this was based on advice we were getting from colleagues in Asia and Europe, was you have to expand your capacity. I know you all have heard about flatten the curve, and I'm suspecting you all understand that flattening the curve is not about eradication. That's not about getting rid of the virus and containing it to the point that no one gets it anymore. It's just about stretching out the number of cases so that you have hospital ICU capacity to handle the number of cases. They can't all come in at once. We did the best we could with the resources we had and tried to lift the bar, namely expand our ICU capacity. And the way we did that was, I think, pretty impressive and a testament to a lot of hard work by a lot of engaged people. We opened something called the Icu. So this is the Respiratory Isolation Care Unit. We basically, from scratch, created an ICU in about 2 weeks. It was an existing ward in Mott, our children's hospital, which is adjacent to our main hospital. And it was built, when they built Mott, they anticipated having this and did not put it to use. I trained in it years ago when Ebola was a concern, but it basically sat dormant. And then over the course of about 2 weeks, they put together an ICU, which is a lot of work. It's a lot of staff, personnel, scheduling, resources, getting equipment. And it was basically a lockdown unit. It was where you see these folks standing now is an airlock. So you would go through these doors, they would close, negative pressure, would evacuate the room or turn the air over in the room, and then you would open up the other door. We went from basically the announcement that we were going to open it to admitting our first patient in about 2 weeks. The initial vision was every COVID patient would go to the Icu, no matter how sick they were. And there's a wide range of you've got COVID, you're not all that sick, so you can go home, to you're sick enough to be in the hospital, but you don't need the ICU, to you're critically ill and you need mechanical ventilation and need to be in the ICU. It was really clear within about a week that we needed these beds for critically ill patients. So it went from what was going to be a sort of all-comers COVID unit to just an ICU dedicated for people with COVID and respiratory failure. We came within a few days of opening a field hospital. So this is a photo of the indoor track stadium here at Michigan. And it was, they were fully prepared. They brought in the Army Corps of Engineers to turn this into basically a pop-up hospital with beds. They were going to run oxygen. My wife, who's a general pediatrician, was on call. And one remarkable thing about all of this is that people were being stretched to do things they don't typically do. So my wife would have been caring for adults in a way that she was not trained to do. In the Icu, we had people, pediatric ICU physicians who were not accustomed to caring for adults, caring for them. Respiratory therapists from other parts of the hospital caring for adults. But it did not come to that. Thankfully, we flattened the curve just enough that we basically approached capacity of our hospital with this 60-bed ICU and didn't need to spill over into the field hospital. But something interesting that I quickly got used to, but this was a very weird thing to me, which is it's 2 beds in a single ICU room. ICU rooms are usually 1-to-1 nursing. You got 1 nurse, 1 patient, especially with someone with a respiratory virus or who needs to be in respiratory isolation. But just to increase our capacity, we were doubling up. So it was basically 30 rooms that could handle 60 beds, and we filled it quite quickly. How did it go? How it went? We got a lot of patients quickly. This is a curve showing the number of mechanically ventilated patients in our hospital, at our center, not just in the RICU, but all over, from basically mid-March to the end of May. The blue line is all comers, anyone who required mechanical ventilation, a breathing machine. The red is patients who had COVID. So you can see that they were awfully close to each other. 80 to 90% of all intubated patients were intubated for COVID. The only reason that's the case is because we did our best to empty the ICUs before the surge. So how do you do that? You cancel all elective surgeries. You minimize procedures, you evacuate, you turn down transfers that aren't essential, and we try to be accommodating of hospitals around the state. But we basically took our 6D, our medical ICU, and evacuated it and did our best to turn every regular room into a negative pressure room. And did it relatively effectively. We had all kinds of sort of spillover plans so that there are certain therapies that you would never offer on the floor outside of the ICU, like heated high flow nasal cannula. It's a way of delivering oxygen that you don't have to be intubated before. We equipped floor rooms to be able to do that. So we basically expanded the capacity of what we could do for these patients outside of the ICU. But this was a lot. At one point we had 110, 120 COVID patients who were sick enough to require mechanical ventilation being put to sleep and with a tube in their throat on the mechanical ventilator. We survived the surge. The curve did drop, but what I'll point out is that it didn't go to 0. So at the end of May, start of June, it was 20. Around that time, we closed the unit. We closed the RICU because it didn't make sense to keep it up because we could accommodate it in other ICUs. I had the strange experience of closing down a unit. I've closed down bars before. I've never been the last guy to leave an ICU, but in June 8th, we sent our last COVID patient out to another ICU so that we could shut it down. The RICU remains dormant now. We are potentially, it's there to be opened up again. We're hoping it doesn't come to it. We're hoping that the curve is flattened enough indefinitely, and of course the vaccine and everything prevents that from happening again. But we do know that we have capacity, and we also had enough in terms of ventilators, dialysis machines. We were out in front of that, and I think we'd actually done a fair amount of disaster planning back in the Ebola scare a few years ago. That paid off in this case. I'll pause there. I said I wasn't going to monologue, but I am absolutely monologuing. Next thing I'll talk about is the clinical course of COVID. Questions so far? So the clinical course of COVID-19 and what it looks like up close. In some respects, it looks like other bad respiratory viruses. I'm sure you've all been screened several hundred times now, and you've been asked if you have fevers, chills, sweats, cough, shortness of breath, anything like that. What is striking to me about COVID is, of course, the numbers, just the volume of patients who are coming in with symptoms from COVID, which makes you start noticing patterns and seeing things, and that you might not notice if it was just sporadic. But the crazy heterogeneity of patients. This is the same virus having profoundly different effects on people who otherwise should be the same. The most common course were people who would come to the hospital or be transferred to the hospital with these sort of systemic, fever, chills, sweats, myalgias, that stuff. If they had an oxygen requirement, so they had a low oxygen level, we put oxygen on and put them on the floor, most would still be okay. Most would ride that out, go home. But a minority of them would pretty quickly, over the course of a few hours, just have a dramatic increase in their oxygen requirement. And what was happening is they were developing severe lung inflammation, severe lung injury, and what we call ARDS, the Acute Respiratory Distress Syndrome, which happens to be the disease that I study. And it looks on an X-ray like you have white, you have just fluff filling both lungs. And that's due to leak, it's due to inflammation, just irritation from the virus itself. The oxygen requirement would increase dramatically, and they would go from needing just like 2 or 3 liters nasal cannula, just minimal amount of oxygen, to needing a face mask, to needing high flow nasal cannula, so pumping 30 liters of oxygen in a minute, to needing mechanical ventilation, and that would happen pretty quickly over the course of hours. By the time things were really surging here in Michigan, we would have a fair number of patients coming in from the floor, but just as often it would be spillover from ICUs in Detroit. And one thing that when I talk about clinical course, a very reasonable question people want to know is, what's the mortality of COVID? What's the mortality of patients who need to go to the ICU with COVID? And I'll show you, this gives you a sense of our own internal data. So this is all from the University of Michigan. This is a time to event curve. So on the x-axis, it's days. So from the time that patients got mechanical ventilation, from 0 to 28 days. The y-axis is the percentage of them that are alive and breathing independently. So are you recovered enough to be extubated and breathing on your own? So a good outcome. The red line is COVID. And then the blue line is people who have the same kind of lung injury that COVID causes, but from other causes, whether it's influenza or sepsis or aspiration or some other cause. And what you can see is, for one, they're actually pretty similar. At 28 days, the outcomes are about the same and not terrible compared to what we were worried about. So we had been told from the early Chinese reports that it was on the order of 90% mortality for these patients. But most of our patients eventually got off the ventilator, left the ICU, and did okay. But one thing you notice is it takes a while. So if we look for at what point 50% of them were off the ventilator, it is until about 3 weeks. So what that means is the median duration of mechanical ventilation is 3 weeks, which is just an awfully long time. So very, very few people with COVID were sort of a quick turnaround. Like, they were sick, they got hypoxemic, we needed to give them 2 or 3 days of mechanical ventilation, but we got them off the ventilator and they left. That would be a more typical course for a lot of patients with hypoxic respiratory failure. The features I noticed were very, very persistent, compatible with other types of severe lung injury like this. But the point I want to make is, when you're asking what explains the mortality of COVID, typically we divide our thinking into patient factors, provider factors. So on the patient factor side, it would be comorbidities, age, genetic predisposition, things like that. On the provider side, management. What decisions did we make? What drugs did we give? How did we ventilate them? How did we provide supportive care in the ICU? I am quite convinced that with COVID, the single most determinant factor is system factors, not patient, not provider, but system factors. So the best way I can make this point is that down the road at Henry Ford, which is an absolutely excellent hospital with I think clinically there are physicians and nurses and respiratory therapists are every bit as good as ours, but their mortality was on the order of about 60 to 70% for the same population. Ours was about 35%. And it's not because we were doing a better job than they were, it's because they were practicing disaster medicine. It just came down to triaging who could get a ventilator, who you had to have a hard conversation with about, we simply just don't have the resources, who you could just sit in your ER waiting for a hospital to accept them. So it really, to my mind, speaks to the importance of disaster planning, flattening the curve, and it's really a sort of societal factor, less than a biologic one. I don't think there's, I do think it's a fascinating biologic question of what explains the heterogeneity on a patient level. I cannot explain why the same 2 patients get such widely different courses in terms of severity. And I think that's probably the most important question we need to answer, to tackle. But the clinical course, I think, was in large part determined by structural, systemic, societal factors. It is a horrible disease. I don't want to minimize it. 35% mortality, which is about what we had for again, critically ill patients, patients who needed the ventilator, is too high. And every loss of life is a tragedy. But like I said early on, the reports we're hearing from China was on the order of 90% mortality. And it was really important for us to know that there were wins. There were people that were super sick, were in the ICU, were on life support, and made it out and did very well. All 3 of these patients are happy to share their photos and share their stories. All 3 were intubated, and not just for a day or 2, but for a sustained period. All of them, you would have been very, very concerned if you saw them. They were really on death's door, on life support. Something Michigan does well that we're proud of is post-ICU care. So the sort of cultural tradition in the ICU is that we fix them and then we send them out of the ICU and then they go about their lives and we sort of stop thinking about them. But one thing Michigan has been thinking hard about is what are the sequelae, what are the chronic consequences of critical illness? And I would say it's too soon to tell with COVID. Literally, we've been treating it for 5 months now, so we just don't know what the 6-month, 12-month, 2-year outcomes are. But one thing we have is a post-ICU clinic here that's staffed by ICU doctors. And that's one way that we get follow-up on these patients, and we can both learn, sort of like close that feedback loop and learn about long-term consequences of decisions we make in the ICU, but also recruit them for trials, study them, study long-term sequelae of critical illness, and get stories like this that are, it sort of puts wind in the sails of the providers when you bring this back and show them to the nurses, and they remember this patient and the sort of grueling end-of-life discussions we were having with the family. I will pause there. Questions or comments on the clinical course?
Bob, I actually had a question. When you were talking about the systematic factors that kind of went into the patient outcomes and mortality, if there was a patient in the Detroit area at some point, were they just going, I mean, would people go to their local hospital and then they got transferred from that hospital, or were patients just going directly to University of Michigan? Like, how did that, how does that?
It was more the former. It was more like, you know, this is an interesting thing, is that basically no one shops for an ICU. You shop for a labor and delivery floor, right? You shop for where you're going to deliver your kid. You shop for where you're going to get your cancer care. You shop for where you get your coronary bypass surgery. That's why those places are all well decorated with nice lobbies and fountains and stuff. ICUs, you pretty much go where you get sick, where the ambulance brings you. So it was much more the former. The ICUs were overflowing, the emergency departments were overflowing in Detroit, and they would come to us. It was dramatic. So I trained in Seattle before coming here. Colleagues trained in Chicago, and just literally the complexion of the patients. So we had suddenly many more African American patients than you would typically see in Ann Arbor. Something brutal about COVID is the distancing with the family. So for totally legitimate reasons, we were very strict about who could come visit. So family members could not come in if the patient was COVID positive in the hospital. And that didn't matter if you were down the street in Ann Arbor or if you were in Detroit. But maybe the most important thing we do in the ICU is communicate with families and clarify goals of care, make sure that the aggressive things we're doing are congruent with what the patient would want. And that couldn't be more challenging. Trying to do that via FaceTime or phone calls. The patients are distanced from their family. They can't be reassured by having them at the bedside. The families are removed and can't see or talk to the nurses directly or see what's going on. And there are historic reasons why there might be tension between the Detroit population and Ann Arbor. And I would argue that was compounded by the distance that came from just the realities of not being able to sit down in a room and talk to people. So that was that was very challenging for patients.
Bob, this is Pierre. I have a question, if you don't mind. I mean, first of all, thank you so much for being here.
Oh, for sure.
So I want to ask you, you know, in looking at the press coverage of this, we heard about a syndromic presentation relating to COVID that affected children more specifically. I wonder whether you would tell us about your experience of how children fared compared to the adult population.
Yeah, it's a very good question. My wife's a general pediatrician and is very concerned about that. We have not seen too much about that. Now, they present with something that's kind of like Kawasaki syndrome, sort of like a vasculitis, is what the reports are. That's thankfully rare. Like one of the few blessings of COVID is that children, they certainly can get infected, they certainly can transmit, but they just don't get nearly as sick as adults when it comes to the viral pneumonia, the lung injury that we're describing here. And I also I don't provide care for children, but basically when I was in the RICU, there was I think 1 or 2 pediatric admissions. They were not too ill and they did not have the syndrome you're describing. So thankfully that's not a terribly common presentation for it, but it certainly exists.
Thanks.
Sure. The toll on providers. So early on, it was very clear, and talking to colleagues in China, that healthcare workers were at high risk for contracting COVID and getting sick from it. And there were conspicuous deaths, very visible deaths. So I don't know if you know the story, but there was an ophthalmologist who sort of a whistleblower in Wuhan saying there's a horrible virus and they're not really reporting it, and he died of COVID. There were intensivists in Italy who died of COVID. It's been, and early on in my RICU time, some of the sickest patients I saw were healthcare providers. So doctors, nurses, OR techs, And it was quite apparent early on that we would have to take special precautions. It was unclear how strict we had to be about it, but we, most of us found some way to distance ourselves from our families. The way ICU work tends to be shift-based. So I will work 1 week at a time and then go off, or 2 weeks at a time and then go off. I'll be the day guy or the night guy, and the nurses work in a similar rotation, similar with respiratory therapists. Most folks would either stay in the guest room, you know, you would wear scrubs, you would change out, you would run to the shower, and then you would distance yourself from your family as best you could while you're at home. I have 3 kids, they're 9, 6, and 3. Our house isn't that big. There was no realistic way that I could distance myself from them, and I was going to be on service a lot. I was going to spend weeks in the RICU. My wife's a pediatrician. She was going to be potentially exposed as well. And we had the luxury of her sibling having kids and saying, we can take care of them. So we shipped our kids away for a month, 5 weeks. Others, when they came back and I would go on service, I would get an Airbnb in Ypsilanti and just stay in a little studio apartment there. The university provided some housing. Some of the dorms were converted for provider housing. I am fully aware that that is a privilege of having the means of doing so. Not everyone has that. And the exact same concerns apply to the environmental services folks, the nurses, the respiratory therapists, the radiology technicians, and all that. Early on, it was, I sort of think of it in terms of there's a volunteer army and a conscripted army, right? The RICU was initially a volunteer army, like everyone working there had signed up for it. So it wasn't fun, but there was a certain camaraderie. There was a sense of like, this is a sort of once in a generation, but like once in a century sort of call. Like we have to do what we do for these patients. They're vulnerable. We have to put ourselves at risk for it. So we were providing care for these patients, and I might be working with a respiratory therapist from the pediatric hospital and a nurse from the neurosurgery ICU. And there's a sort of like collision of cultures, and we're learning from each other, and it was sort of like all hands on deck. And there was a perception of tremendous community support. People were putting signs in our yard saying, "Thank you, healthcare providers." A gas station attendant saw me in scrubs and said, "Thank you for your service," which no one has ever said to me before. I felt like a veteran wearing scrubs. I'm sorry, wearing fatigues at the airport or something like that. People would send in food. All of this helped. All of this sort of created a spirit of help with morale. But that was only the first wave, and it couldn't be a volunteer army forever. And within 2-3 weeks, it was sort of an all hands on deck, whether you like it or not. So to give you an example, they shut down the ORs, right? Like they canceled all elective procedures so that they could open up hospital beds and ICU beds for COVID patients. So we had all these anesthesia residents, right? So these are clinical trainees who are in their anesthesia training, but there's no operating room, so they can't be doing OR work. But they have some ICU experience, so they put them to work. And they couldn't just rely on nurses and therapists who volunteered for it. So it kind of became a mandatory requirement of everyone. Like there was no one who was not going to be caring for it. We had COVID patients in every ICU. So again, ICUs that typically don't even handle respiratory failure as a sort of bread and butter daily diagnosis. Like I mentioned, the pediatric ICU was handling, this is to Pierre's question, they had so few pediatric cases that they were handling adult cases. And something that really evolved is that kind of like the sort of Rosie the Riveter, all hands on deck morale thing kind of shifted. And I pointed out that the surge never really went away entirely. And many of us are still caring for COVID patients. And it feels like, and I'll get to this when I get to frustrations and disappointments. There was a shift that happened after the first few weeks where you would see things like sort of top down, like I'll just say it, like the president calling it a hoax, or saying that the only reason we have this many cases is because we're doing all this testing, is really just pops the bubble of morale. And it feels like, what are we doing this if we're not getting supported from the top down? A lot of my colleagues got infected. My boss got infected. The head of pulmonary and critical care medicine was infected. A pharmacist, several colleagues, a number of nurses. Thankfully, none of them were critically ill. Internationally, a lot of my collaborators and colleagues have gotten infected. So it's, there's no way to sugarcoat it. It's been very disruptive to families. It's been disruptive to, most of us are doing something else. I mentioned I spend most of my time in the lab, mentoring, doing research, and this was asking a sacrifice from my lab as well, in addition to the sacrifice that every PI has made and every trainee as well. So that's just some personal reflections on the toll it was to providers, and I guess the message I want to send is that it's just not over. That this wasn't something we got through. It wasn't like mission accomplished. We got through March and April and May. It's still an ongoing ask of everybody. One of our internal medicine residents, who again, it's a trainee, and initially we were trying to protect them from coverage, was infected, or we found out was infected earlier this week. So the UM community contributed quite a bit. I already mentioned that early on. There was definitely a fantastic spirit of how can we help. And I could list any of a number of ways of things like food drives, things like donating PPE, things like volunteering to man the check-in stations, things like offering research support, things like offering the clinical micro lab a set of hands that are skilled with a pipetter to run more PCRs. That put wind in our sails. That helped us feel like we were really supported. I think I had another slide on that, but and then I'll come back to specifically how U of M research efforts were kind of molded and informed by this. But my critiques and my disappointments are much more at the sort of like federal level than the local university or state, county or state level report. I will moan for a bit about some frustrations and disappointments. I already mentioned I was not expecting and am profoundly disappointed by the politicization of our disaster response. I feel like sometime in March there was like a 2-week window where it really felt like this is our, I don't know, World War II, this is our all hands on deck, we're all in this together moment. And then it just got so toxic. The calling it a hoax, the politicization of masks, the politicization of Plaquenil. Yeah, this I find fascinating. I'm a nerd for history. I'm sure you all know, so hydroxychloroquine is a very old anti-malarial. There is an eccentric and I think misguided and unprofessional senior investigator in France named Didier Raoul. Any of the micro grad students should look him up. He's one of these guys that publishes more manuscripts a year than you can possibly read, and they're of highly variable quality. He put out a really sloppily done study suggesting a remarkable, implausible benefit of hydroxychloroquine, Plaquenil, which is an anti-malarial drug that is given for autoimmune disease like lupus. And the Trump administration latched onto it and said, this is a game changer. What could the harm be? It's clearly gonna fix this. This is a political cartoon from 1890, from not even the 1918 Spanish flu. This was an influenza epidemic from that. And here's an influenza-stricken patient here. Here's a parade of basically like quacks, doctors trying to like force things on him. Excuse me. And in the bottom right-hand corner, you see la quinine, which is quinine, which is sort of a parent of hydroxychloroquine, which even back in 1890, we were making fun of the idea that these antimalarials were going to do anything about this viral infection. And basically every viral pandemic, someone has thrown hydroxychloroquine or chloroquine or some version of it at it. It was all seemed so cynical from the start. And I'll come back to the opportunity cost of that, but a really disappointing thing. Even this week, I'm sure you all heard this, but the CDC changed its guidelines about what we saw. I'm the county TB doctor, and what we call is contact tracing. It's not unique to TB, but if you know that someone has a communicable disease like tuberculosis or COVID, you don't just wait for people to become symptomatic. You have an opportunity to contain it. So you screen the asymptomatic close contacts. So people living in the same household who've been sharing a lot of the same airspace. And that is the appropriate thing to do to COVID, and there's no good argument against it, unless you are rationing tests, which is not the argument here. And President Trump thinks that more tests means more cases, so we should have fewer tests. And the CDC got top-down direction to stop screening asymptomatic people. And it's just so cynical and really, really frustrating, and it doesn't feel like a team effort, frankly. I have been very disappointed. This is the academic side of me, but as a clinician, I am dependent on trustworthy data from peer-reviewed journals. And I've been very disappointed by what I would consider a failure of peer review in the editorial process in so many ways. I have colleagues that badmouth preprints, and there's been no question there have been plenty of bad preprints that have been put out in the PubMed in the COVID era. I don't think that's the problem. I think far more damage has come from glam journals, specifically on the clinical side, like JAMA, New England Journal of Medicine, rushing to publication things that have not been thoroughly vetted, things that would not meet the rigor of in a non-COVID era. I'll give you one specific example that I think had really concrete repercussions. So JAMA published this. So this is presenting characteristics, comorbidities, and outcomes among 5,700 patients hospitalized with COVID-19 in the New York City area. And this is huge, it's very large, almost 6,000 patients. And this was early. This is mid-April. And this was going to tell us what to expect in terms of clinical features, clinical course, and outcomes for patients with COVID. Excuse me. And they said in the abstract, which you know is the only thing anyone reads, mortality for those requiring mechanical ventilation was 88.1%, so almost 90%, which is awfully high and terrifying, right? And the press got a hold of it, and you could see headlines like this. New study shows nearly 9 in 10 COVID-19 patients with ventilators don't make it. Nearly 9 in 10 COVID-19 patients who are put on a ventilator die, New York Hospital data suggests. You have to read much more closely and actually know something about how they're doing this. The median follow-up at the time of censoring was 4.5 days. So you want to say from the time the tube goes in until a reasonable time afterwards, let's just say 28 days of mechanical ventilation, how many are alive and off the ventilator? That's the figure I showed you. And I told you that at our center, 28-day mortality was 35%, way different from this. What if you don't have 28 days of follow-up on every patient? You have to censor. You have to lower your denominator so that at later time points, week 1, week 2, week 3, you're only looking at a third, a quarter, a small fraction of the total patients. I hope that makes sense. And here, what they're saying is that for half the patients, they didn't have more than 4.5 days worth of data. So basically, for anyone who, any time point after 4.5 days, they're dropping more than half of their population. So really what that number means, that 88.1%, is that for patients where they knew the outcome at 4.5 days, namely you were either extubated and alive or dead, the mortality was 88.1%, which is an entirely inappropriate way of figuring that out. When people want to say, what's the mortality of patients with COVID in a mechanical ventilator? They're not saying after 4.5 days. They want to know after several weeks, right? After an ICU course. And the JAMA had to retract that and adjust it and change the wording of the abstract. But I can tell you that that had real consequences. So we would have patients who were critically ill, who had worsening oxygenation, and we'd be having family meetings. We'd be talking to them. We'd be talking to their family, and they would say, "I've heard that if you need to use the breathing machine in COVID, you're almost certainly going to die. There's a 90% chance you're going to die," and that's what they read. And it's very hard to undo the damage that caused. That's just one example. I could spend the entire hour talking about frustrations from glam journals that I think really prioritized getting a splashy headline, getting clicks, getting citations. That's in a sense always true, but and just racing. I think I value more than ever a slow, deliberative process when it comes to science. I was frustrated by the abandonment of evidence-based medicine. So I am a strong advocate that I love physiology. I love bedside reasoning, trying to think through the pathophysiology of what's going on. But at the end of the day, our biologic intuitions can steer us wrong. It's easy to be led astray by what you think is going on. What you really need is robust clinical data. Like in this context, when we study it in a large randomized controlled trial, what can we learn from it? What's the best course of action? And for a lot of things with COVID, there was just, we all sort of said, oh, we're not going to have time to do randomized controlled trials. We've got to make decisions now. I've got a patient in front of me, so what are we going to do? So there were decisions made based on biologic hunches that were just straight up wrong. So I won't go into it at length, but the physiology of lung injury is something that we've been studying for 50 years. And there was a very highly influential, I'm sorry, but old white guy from Italy who published a very influential paper just saying, in our early experience with literally 16 observations, we had found that the physiology of COVID is not compatible with ARDS, with the other lung injury that you've been studying for a long time. So we should ventilate it differently. You don't need to use the same ventilator strategies that we've been using for ARDS. And within a month, we had enough data. This is not an uncommon diagnosis to thoroughly refute that. Just show quite unambiguously the physiology of this is exactly what you'd expect based on flu or any other severe viral pneumonia causing lung injury, and we shouldn't be changing our practices, but you can't undo the damage of that. JAMA ran his editorial saying as much. There were things like this. So corticosteroids, so anti-inflammatories like prednisone. We've been using them in lung injury for a long time. We've been studying them, and the best study for ARDS, the type of lung injury that COVID causes, was at the end of last year, and it suggested a mortality benefit. So that might have been the default practice. But there is a concern, and a not unreasonable concern, that in viral infections, immunosuppression may not be a good thing. You may impair viral clearance and make the infection last longer. So the initial recommendations were, we don't really have data on steroids in COVID lung injury. Based on inferences from flu, let's not use it. But these people seem really hyper-inflammatory. And if you measure cytokines, they're really high. And it got thrown around that these patients have a cytokine storm, which was said as if it was meaningful, but it's really not. There are a lot of, the idea that the lung injury in COVID and lung injury in general is caused by dysregulated immunity is basically the oldest idea there is in critical care, and it has not served us well for a very long time. And arguably the immune response in critical illness is zero sum. You really can't dampen it down without increasing susceptibility to secondary infections or impaired clearance. But that didn't stop us from giving all these patients IL-6 inhibition. So we would give them drugs like tocilizumab because we thought, oh, they're cytokine storming. They're having dysregulated immune response. So there's a friction between, we actually had clinical data suggesting a mortality advantage to corticosteroids, which are potent anti-inflammatories, but we're gonna not use it. We have a biologic intuition that this is a cytokine storm that we should blunt with immunologics. So we were giving anti-IL-6 therapies, which are expensive and pretty much untested. We've never given them to critically ill patients before. And that just became routine and almost standard of care. Sure enough, several months later, we actually had randomized controlled trials telling us that, lo and behold, dexamethasone, a corticosteroid, has a mortality benefit, and IL-6 inhibition doesn't work. So that's a relatively, I don't think we hurt people with tocilizumab. I think we maybe clouded the picture and spent more money than we needed to. But there are things like, there's this idea that it is coagulopathy, primarily a problem of coagulation within the lungs. And people are getting TPA, thrombolytics, which is a dangerous therapy. Like, you can cause head bleeds by giving people thrombolysis. And they were just giving them empirically and publishing it proudly, saying, look, we're giving TPA to patients with no demonstrated clot. That I thought was pretty reckless. And I am more entrenched than ever in the idea that we really should be basing our decisions on sound data, not biologic intuitions. And I say that as a biologist. And then the last thing I'll just say is the opportunity cost of unsupported ideas. Everyone wants to help. Everyone wants to throw out an idea and say, maybe this is the secret. And what we saw in medicine was a lot of people from other fields, adjacent fields, like rheumatology, saying maybe you should try like immune modulation, oncology, gastroenterology, and everyone means well. But what I'd point out is that you only have so many patients that you can study, and every trial that you do, if you enroll a patient for it, you may be boxing them out from another more plausible or more biologically interesting or expected to work therapy. My biggest frustration with that is Plaquenil. I don't think anyone really seriously thought that hydroxychloroquine was going to be the game changer that it was pitched as. And yet our, what we call PEDALs, it's like Ards, it's like our big multi-center ARDS trial network. You only have so many points to spend. They spent their points on Plaquenil. So they studied this drug in a multi-center network trial. So we're going to have 200 studies telling us that Plaquenil doesn't work. And there are basic questions that are going to go unanswered because of that. So that's been a frustration of mine, is that we basically just said, what's the harm? Why not? And then just threw a bunch of unproven therapies at patients to the exclusion of a really, I think, biologically informed way of rationing our clinical research points, if that makes sense. Let me rebound from that and give you what I think are some reasons for optimism. So I mentioned I'm a nerd for history. I really like this era. We know that great innovations emerge from times of crisis. So between about 1945 and 1955, three amazing things happened. One is penicillin went into widespread use. Penicillin wasn't invented in the 40s, it was invented in the 20s. But it took World War II for the British government to notice, you know what, our soldiers are not dying acutely from trauma, they're dying from secondary infections from trauma. And if we had an antimicrobial like penicillin, we could probably save lives. So the British government leaned on US pharma to mass produce penicillin, went into widespread use. So it was World War II that gave us the modern antibiotic era. Within a couple years, so I have to talk about TB slightly, the first randomized controlled trial. So I would argue maybe the single most important technology that came out of the 20th century in terms of biomedical research is the randomized controlled trial. And that came out of a crisis, was namely the British government, their economy was devastated. They didn't have enough money to give streptomycin to everyone with TB, but they had a hunch it would work. So the smart statistician said, you know, we could use this to learn something. If you give it to who you think needs it, you're going to confound it. You're not really going to answer your question. If you flip a coin, randomize it, you will neutralize the confounders and actually answer your question. They did that. It was the first table one, showing that the treatment groups were similar in their baseline demographics and risk factors, and showed an unambiguous benefit to it. So the randomized controlled trial came out of the crisis that was the economic devastation of World War II. And then finally, the existence of my field, the existence of critical care, came out of a polio epidemic in Copenhagen. So this is 1952, I believe. They had more patients with polio and respiratory failure. So polio causes a neuromuscular respiratory failure. You basically can't move your diaphragm. And they only had 1 tank respirator and 6 cuirass respirators. So this is basically negative pressure, like an iron lung. So they had the inspiration to perform a tracheostomy and then pay medical students to do bag valve masking, mask ventilation. And they paid them £1.50 per shift. And the med students would come in and rotate. And this is a touching figure. This is what it looked like. Excuse me. And this is basically the first positive pressure ventilation, like the supportive care we're giving to COVID patients. And there's a med student reading a children's book while providing positive pressure ventilation. So that was the first ICU. That was the first critical care unit. And that came out of an infectious disease outbreak, an epidemic of polio. So I am optimistic that I don't know what the revelations of this era will be, but there are so many ways we can get better at this. As someone who does sequencing of microbes in the respiratory tract, I'm embarrassed by the hiccups when it comes to testing. PCR is a technology from the 1980s, and we clearly need to do a better job of scaling and rapidly detecting and disseminating. We need rapid pathogen detection. The responsible way to open up the economy was to go all in on, in addition to vaccine development, rapid, cheap, accurate testing. We should all have $5 daily tests. And that should have been our moonshot. And that's the way to responsibly open up the schools and the universities again. And that just doesn't seem to have been the priority that it was. But so I am confident 20 years from now, we'll look back and say, yeah, that was the pre-COVID era. We did something different about biomedical research or medicine or diagnostics at the time. But I just don't know what they are. I can tell you U of M has been quite active in the research capacity. And I emphasize here, this is just a few U of M research efforts related to COVID-19. They are biased towards the things I had a hand in. But if you just Google University of Michigan COVID research, you'll find this website that has a catalog of a lot of things going on. And it's worth poking around and seeing what's going on. We have been very active in clinical trials, both as a primary site and also as participating in multi-center studies. Remdesivir is the antiviral that has some benefits. Cerulumab is an anti-IL-6. Hydroxychloroquine, I told you I kind of resent that study. But mesenchymal stem cells, convalescent plasma, defibrotide, dipyrimidiol, these things are endothelium stabilizers. So we're doing that kind of applied at the bedside clinical research. But in terms of long-term potential, what's really exciting to me is we have an amazing biorepository. So basically every surplus specimen from clinical testing from a patient got banked and cataloged. So there is blood, serial blood specimens, respiratory specimens, and it's all matched with an amazing data repository. So Michigan's done an excellent job of investing in data infrastructure. So even 5-10 years ago, data coming off an ICU patient was just lost. And now it's all being captured in exquisite resolution. So like you can actually get waveform data from the EKGs, the ventilator, and it's all time synced. So in terms of just making sense of the colossal amount of biologic data and information coming off of patients, this is going to be an amazing opportunity. And what I won't get into, but you can find on that website is and probably of great interest to this audience, the PIBS audience, is just a whole bunch of basic science that's going to come out of this. Just fundamental questions about, like what I said, I think is the most important biologic question is what explains the heterogeneity and susceptibility to severe illness? Why does the same bug in anatomically the same set of lungs result in such highly variable severity of illness. So there's been a lot of good work going on the immunology side and the virology side. There's been some very practical stuff. So Nicole mentioned I'm an associate director with MCirc, which is meant to bridge the engineering school and the medical school. And early on, our engineers were amazing. You'll see a lot of these projects are sort of engineering related, of sort of dropping what they were doing and going all in on recycling PPE. We're in better shape now than we were back then. I'm used to the idea of recycling an N95, but we developed an in-house way that was adapted from other protocols for using UV light to basically sterilize an N95 so that we could recycle it and use that. We were set up to start manufacturing our own PPE. It didn't come to that. This is neat. Showing in your face. We have a real problem of aerosolization. So one of the ways you can support a patient with COVID is with heated high flow nasal cannula. So I don't know if you can see the cannula that Cindy is wearing here, but it's basically like a very large bore cannula that pumps a lot of oxygen into your nose. And it's a way of giving people a lot of oxygen support without intubating them. The problem is there's a concern that it was highly aerosolizing, and we only have so many negative pressure rooms. So we were inspired by a mask that's used in industrial painting, and we basically jury-rigged a shop vac to provide negative pressure within the hood. So if you see it sort of clearing the smoke here. So this let us provide heated high flow nasal cannula to patients in a non-negative pressure room, give them a little negative pressure space, or even in the hallway of the emergency department. So I thought that was awfully creative and useful. They came up with a larger version of a tent that we could provide procedures. We were initially concerned about doing tracheostomies on patients, but with this sort of like contained negative pressure environment, we were able to do it more safely. This is neat. It's wild to me that we would be giving this anti-IL-6 therapy to patients, an IL-6 inhibitor. We would draw blood and then send it for IL-6 testing. It's a send out lab. 3 days later, it would come back and say it actually wasn't that high to begin with. But by that point, you've already given them an expensive monoclonal antibody that's supposed to block IL-6. So it's a little embarrassing that in 2020, we actually can't measure cytokines clinically in any kind of relevant time frame. One of our engineers, Katsuo, has developed a digital ELISA, and a colleague of mine, Ben Singer, is working with him and has gotten some pretty good validation data indicating that we can do about 2-hour turnaround time. And I'm sure you've heard the buzzwords of precision medicine and tailoring the therapy to the specific biology of the patient in front of you. I think that's a pipe dream unless we can actually get biologically meaningful measurements. So this idea of a bedside digital ELISA is pretty exciting to me. And this is a very, again, I'm much more of a sort of pathogenesis, microbiome and lung injury kind of guy, but I'm involved in this project, which is awfully exciting to me as an intensivist. We need CT scans for patients, and X-ray only goes so far. A CT scan gives you 3-dimensional look at the insides of a patient, but COVID patients are quite communicable. You don't want to wheel a patient from the ICU down to radiology and back and expose people to it. We also wanted to do, I showed you that field hospital we almost built, or we started to build and didn't end up using. That place was not going to have CT scanners. They might have plain films, just regular X-rays, but if you want a CT scanner, you need 3-foot floors, or I'm sorry, steel reinforced floors and cement walls and stuff. There's a company in Ann Arbor named Zoran that makes portable head CT scanners. So we have one, they're meant for dentist office or oral surgeons and neuro ICUs. And we actually have one in our neuro ICU. And a year ago, I went to them and said, we could really use that in a medical ICU to look at lungs and abdomens because our patients get super sick. They're not clinically stable to travel to go down to radiology. And kind of amusingly in retrospect, they didn't think that there'd be enough of a market. And then a global ARDS outbreak, a global pandemic of critical illness and lung injury happened. And they came back to us and they basically dropped everything. And now they are going full steam ahead making this. There's a prototype. I just find this very cool. And the goal is by the end of the calendar year for them to have a working portable CT scanner for the chest that we can have in our unit and validate against the standard. To me, that would actually at the bedside be a transformative technology, and who knows, it could emerge from here in Ann Arbor. So I think I have exhausted both my time and my agenda, so hopefully I've left a few minutes to talk, but thank you, Nicole, for the invitation, and thank you all for bearing with me as I monologue despite my best efforts not to. So I appreciate your time and your attention.
Thank you so much, Bob. That was awesome. Do we have questions? I mean, I have questions, but by all means, people please ask. All right.
Or Are we asking them out loud or should I be typing them in?
Go ahead and ask it out loud, Megan.
Hi. Thanks, Bob. That was awesome.
Thank you.
I wondered if you could comment. I have two questions. You can pick the one to comment on. One is that I personally had a lot of frustration seeing clinicians leaving the hospital and not wearing masks. And I was just wondering if you could comment on the culture or any ways in which that maybe reasons behind that or logic. I was very surprised to see that given the severity of the disease and how hard the hospital is hit. The other option would be, it kind of surprised me that people were attributing all these specific phenomena associated with critically ill patients as very specific to COVID. For example, the coagulopathy, the situation where you just see a highly decompensated patient, and it all looked very consistent from the data I was seeing. And so I was wondering how the decision was made, and maybe this goes more to the lack of peer-reviewed papers, to suddenly target these things, even though they were pretty consistent with a critically ill patient. Okay.
Yeah.
I'll take my answer off the air.
I will. Oh, thank you. I'll answer both your questions. I have a good answer for one and not the other. The clinicians leaving the hospital without masks is unacceptable. I don't have a good answer for you. I don't know. The public instruction on masks has obviously been a moving target. Initially, it was discouraged when we were trying to save PPE for providers. That changed, and now there's no excuse, and everyone, especially providers, leaving a place where they might have contact with COVID patients should be wearing it. So I don't have a good answer for that. The scrubs, I hate seeing people in scrubs outside of the hospital. I will say I was doing it, but we would change, you would go from the RICU, change it, you would bring a set of scrubs that you wore just for travel to and from home. And it's frankly because, so it was not the same scrubs that you would be seeing patients with, is that scrubs are really durable and you can wash them in hot water and just wash the hell out of them, and they're also disposable almost. So I'm less bothered by the scrubs than I used to be, only for that one exception. But the masks don't make sense to me. The second question is exactly, your comment is exactly right, which is a lot of the specific features of COVID that have been sort of fixated on. So like you mentioned, the coagulopathy. I think, and we have data for this, is indistinguishable from other causes of critical illness. So it's no different than people with flu and respiratory failure or sepsis. I'm certain, certainly there are features of the pathogenesis of SARS-CoV-2. Like there's something uniquely bad about it that will be specific to it, just like there are things that are specific to influenza and other pathogens. But I totally agree that, for instance, the cytokine storm, when you actually compare cytokine concentrations and blood levels in patients with COVID, they're lower than most patients with hypoxic respiratory failure due to other infections. So for instance, sepsis and ARDS tend to have much higher cytokine levels. The coagulopathy you mentioned, the specific features of the respiratory physiology, and I think you hit the nail on the head, which is we have I mentioned this one guy, Luciano Gattinoni, published in JAMA with no data saying that the physiology is completely different. This is like nothing we've seen before. We published a data-driven response saying, look, we compared it with a cohort of 350 patients with non-COVID ARDS, and it's indistinguishable. And JAMA said, we admire the rigor of your methods, but it's just not of high enough impact. It's the, the dog bites man versus man bites dog. If you say this is like nothing we've ever seen before, that's going to get newspaper headlines and clicks and citations. If you say that this is very common biology to what we see in other causes of critical illness, it's just not that interesting. I will end on an optimistic note, which is I like to think that that means there's never been a better opportunity to study features of critical illness, right? Like I like to think that some of the things that we're seeing in COVID, we're now seeing in such large numbers that we should be able to learn something from it. So I don't think that huge biorepository and the data repository I mentioned, I don't think that that will be useless once we get a good vaccine for COVID. I think we can learn important things about the biology of other causes of lung disease and multi-organ failure as well.
Bob, there's a question from Lavinia in the chat.
Oh, I don't have the chat window up. Could someone?
Sure. It's how are patients on ventilators nourished? Is there any research on if this impacts the microbiota and potential implications for patient recovery?
Yep, great question. Initially, we don't feed them generally in the hours after the tube goes in, and then generally within a day or so, give them enteral nutrition. So we feed the gut, especially with COVID, when we know that very few of them are going to be off the ventilator within a day or two. They, in extreme cases where their gut just doesn't work, rarely in COVID, but in other causes where you have, say, ischemic bowel or some other cause, we'll feed them through the veins, what they call total parenteral nutrition. So we're getting them calories basically through the vasculature. But we prefer to feed the gut if we can. I would love to know what it does to the microbiome. I am not impressed by any of the data yet out there on it. It sounds like an opportunity for study. I will tell you, to the microbiomeologists in the audience, I don't think we're feeding the microbiome. I don't think we're giving non-digestible starches that make it to the lower gut. So what a rich opportunity for study. So there is ongoing work. We've got, so Bob Woods is one of our infectious disease docs, and he's also, I think he has PIBS students as well. But he has an amazing repository of thousands of rectal swabs from ICU patients. So just an enormous resource where we could characterize the gut microbiota and ask, what does it predict? Does it explain variation in disease trajectory? And we could certainly go back and look at what they were fed, because he has serial swabs, and ask if variation in enteric feeding has a consequence on the microbiome, and if that translates into a functional difference as far as their metabolic products. I think that's a very cool idea.
I had a question about the recent talks of this, like, convalescent plasma treatment that has been going on. Is that like based on studies, or is it just more politicization of COVID?
Yeah, that's a perfect example of something where it's been given very widely now in what's called a compassionate use. I think it's called compassionate use, but basically, like, we know it isn't quite a proven therapy yet. The FDA has said it's okay. There is a study that I don't believe has been fully published, but we have the top line. And just this week, talking about the politicization of science, the head of, I believe it was the head of the FDA, inappropriately said he confused relative risk or relative benefit with absolute benefit. Namely, in this single study, it appeared that this convalescent plasma decreased mortality from, let's just say, 9% to 6%. That's a 3% absolute difference in mortality, right? But 3 is 33% of 9, so you could say it's a 33% relative benefit. And he utterly inappropriately said 35 out of 100 patients with COVID would have died had they not gotten this therapy. So that's the kind of, like, he should know better, and it's clearly because they want a clear, unambiguous win. I am inquiring today. It's available in a compassionate use. You have to lobby for it. I do not think the data is as good as dexamethasone. I was very impressed by the dexamethasone study, but I don't think there'll be everyone wants a game changer. I don't think it's going to be. I think often by the time they're in the ICU, the virus has largely done its damage, and what you're dealing with is persistent lung injury. So if I were calling the shots, I would be putting a lot more research efforts into things like alveolar epithelial repair. How do we get recovery from lung injury, rather than just trying to sort of patch over the inflammatory cascade or stop viral replication. But that said, I think the dexamethasone study was impressive, and I don't doubt that antivirals have a role at some point in the disease process.
Hi, there's a question in the chat. I just wanted to read it to you, and then I also have a question of my own.
Yep.
The question from the chat from Jacob is, I remember previously seeing publications and news stories relating to the neurological complications in critically ill COVID patients. What is the experience from the University of Michigan in this area? Thank you for the informative presentation.
Sure. The neurologic sequelae of COVID, we don't yet know if they're any different from the neurologic sequelae of other kinds of critical illness. This comes back to the question earlier. We have folks that study this, and again, Michigan's been really a lead in this, is that you can't just end your study at 28 days and say it's a win because you have a difference in mortality. You need to look at those patients at 6 months, 1 year, 2 years, ask about their functional deficits, their neurocognitive sequelae. And we know that sepsis, ARDS, these diseases that get you into the ICU, have long-term neurologic consequences that we don't fully understand. It's not as simple as inadequate oxygen to the brain. It's not an anoxic brain injury. There is some kind of persistent immune difference and functional difference in neurocognition later. And it's just too soon to tell if there's anything unique to COVID. My bias is that it's probably not intrinsically different from what we're seeing, what we call post-intensive care syndrome from other causes, but time will tell.
I have a really quick question. So in all of the samples you guys have collected, have you also been able to collect like microbiome samples from the lung so you could see how the lung microbiome might be changing?
Tragically, no. So one of the, that's my bread and butter. And I wish for every one of these patients I could have been there doing a bronchoscopy where I stick a scope in, spray saline and suck it back out. But that is a very aerosolizing procedure. And we were all very strict from early on saying that we were going to minimize aerosolizing procedures. So we did get some clinical specimens where patients, you suspected pneumonia, so you just do an endotracheal aspirate. So you just suction sputum or secretions from the endotracheal tube. We'll have some of those to work with, but it's really not quite, it's not really the gold standard. It's not the bronchial lavage specimen we want. We do have a lot of nasopharyngeal specimens. So Mike Bachman and Adam Loring have been working with that and are happy to collaborate. And we can look and see if there's differences in upper respiratory tract microbiota. And I have a collaborator in France who just sent me a beautiful cohort of oropharyngeal microbiota in very well characterized COVID patients. So we will get some respiratory microbiome work, and we'll ask that may be an important source of, there's great data in kids suggesting that pharyngeal microbiota inform and predict susceptibility to respiratory infections, that certain communities are more or less hospitable to being taken over by a viral infection. So I think that's plausible, and that's a question we might be able to answer. But unfortunately, we're not going to get good lower respiratory tract specimens just because of the nature of the aerosolizing procedure. Again, I can't see the chat with my screen, so if there's any others, please let me know.
Oh yes, there are 2 more questions. So let's see. Do you think treating patients earlier would help? It seems often patients don't get admitted to the hospital, then get sent home, they can get readmitted a few days later with super low oxygen. Yeah,
that is a major frustration because, yeah, presumably. I mean, like I said, I think probably if there's a role for antivirals, it's early. If there's a role for immune modulation, it's probably relatively early. And then by the time I have a patient in the ICU now who's been on the ventilator for 2 or 3 weeks, I doubt antivirals or immune suppression is going to do anything for him. So in principle, absolutely. I don't think our current clinical assessment is informed enough to really tell us when to treat who with what. All we have are the sort of entry criteria of you would have qualified for this study where you would have gotten this therapy and you did or did not benefit. So in principle, I'm absolutely there. And you're right that it is, we just can't predict that idiosyncratic heterogeneity of who gets sick and who doesn't. There are plenty of people who, by all demographic factors, this is a personal story, but my wife's parents both got COVID and they did okay. But my wife's great uncle is 102 years old. He was born in 1918, literally during the 1918 pandemic. And he got COVID, was hospitalized. And I was very nervous about this. And we knew he wasn't going to be intubated. He wasn't going to go to the ICU. They got up to 5 liters nasal cannula with oxygen. And by every demographic feature, he should have gotten super sick and died. But they de-escalated. After a week, he left on room air without oxygen, and he's back home living by himself, fixing his own sandwiches, which is just extraordinary. So that heterogeneity and the lack of predictability is a puzzle. It's a mystery to me.
So there's one more question, if you don't mind, Bob, and then I'll let you go. Let's see. This one says, what are your thoughts on the likelihood that there will be satisfactory alternatives to PCR-based tests developed? Also, has the saliva-based collection method been widely adopted yet? If not, why do you think the hesitation? Yeah. And are most tests being done still the nasopharyngeal swabs?
Yeah, to my knowledge, 100% are nasopharyngeal swabs. I may be wrong about that, but I'm pretty sure it's all the called a brain biopsy, but basically stick a swab way back in the nose and do the PCR on that. I would love there to be fast, cheap, informative things like saliva, like other non-PCR based things. And I've heard of others that are in the pipeline. I am not the guy to answer that question. I think that there are regulatory problems. I think that my understanding of the whole PCR problem was that there was a perfectly valid PCR we could have just bought from Germany, but our FDA was insisting that we have US developed techniques. There were barriers to, if you remember, the University of Washington was essentially serving as a diagnostic laboratory kind of behind the back of the FDA. They found some kind of backdoor way of offering testing. So I think, unfortunately, it's probably more regulatory problems than it is scientific problems right now. One thing, I didn't put it up there because it's too narcissistic, but one project I'm working on is nanopore sequencing. So we have shown that you can take a respiratory specimen from an ICU patient, extract DNA, run it through a nanopore sequencer, like a MinION. I don't have one in the room with me, but it looks like a stapler. It's like the size of your hand. And we can use metagenomics of the DNA from that specimen and identify a pathogen like Pseudomonas aeruginosa within hours. So faster than culture, and not PCR, right? It's not targeted, it's just agnostic, sequence it all, and then alignment and see. That, to me, feels like a very promising way to go. Is imagine if you could, if every clinical microlab had a nanopore sequencer, and you had respiratory specimens coming in for clinical diagnostics all the time, and there's an outbreak in Wuhan, China, and they say, here's a stretch of DNA, sort of like digital primers. Like here's a sequence of nucleic acids that is specific to this emerging pathogen. You wouldn't have to disseminate PCR kits throughout the world. You could say, listen for it, sniff for it. That to me sounds like a very cool way. So we got an NSF grant to pursue that, but that's not around the corner. There's a whole lot of technical problems that are in the way of getting there. But yeah, I would love to 20 years from now say, like, remember when we used PCR? That seemed like such a clunky way. Now we have these, bedside point of care, exquisitely sensitive and specific tests. If ever there's been an argument for that, COVID is it.
Thank you so much, Bob. That was such a great presentation and such a great perspective to get. So I think in the future, I'm going to ask you all my medical questions. So yeah, thanks for that.
It's either only if they're about TB or ARDS, and I hope you have neither of those. So.
Yeah, fair point.
I know some other smart dogs. So.
Thanks, Bob. We'll let you go. We really appreciate you taking the time to do this.
Thank you very much. Thanks, guys.